My name is Jennifer Zeitlin, and I'm a perinatal epidemiologist, and I work in a research team that does epidemiological research in obstetric, perinatal, and pediatric health and care at INSERM in Paris. And INSERM is the National Institute for Health and Medical Research in France, and it's where a large part of the biomedical research is done in France. My talk is about differences in perinatal care and outcomes in Europe, and it's very different from the talks that you heard yesterday. We're not going to be talking about an individual patient, but we'll be talking about populations and how comparing across populations can give us information about outcomes and care. I think it's a source of information that should be used with care, but is an important part of the toolkit when we're thinking about how to improve care and outcomes. So I just wanted to start by reminding us all that globally, one of the biggest predictors of good perinatal health is the level of development and national income. And this is a graph that looks at the infant mortality rate with respect to the gross national product in different countries. And what we can see is that very clearly, standards of living, access to care are going to determine pregnancy outcomes in a lot of cases. However, what you'll also notice from the graph is the shape of this curve, and it flattens out, and indeed, this is not true any longer in recent times in Europe. And these blue dots are, this is neonatal mortality, and this is GDP per capita in constant dollars across the time period. And this is in 1970, and for countries in Europe, we see that there's still this gradient. In other words, countries that have lower income, national level income have higher mortality. And then by 2000, the countries in blue in this graph are the ones in the darker red here. That curve has flattened out, and there is not a strong association between countries' level of income and its perinatal outcomes. And I just double-checked this with some more recent data from 2010. This is a correlation, and this is, again, per capita GDP. This is the neonatal mortality rate. Oh, sorry, this is the stillbirth rate. And what you see is that this is really quite flat, and the same for the neonatal mortality. So this is what's interesting about the European context. One, similar standards of living in high-resource countries. So there are similar standards, access to basic needs. There's similar access to scientific knowledge through medical education that's high quality and access to scientific articles at universities. Most European countries provide universal insurance coverage, and in particular to the population of mothers and children. And most countries have maternity benefits for women. The European context is also interesting because the European Union exists, and although health is not a big part of the European Union's mandate, there has been a research program that has encouraged research and the development of research on health outcomes. And several projects, many projects in maternal child health, which began in the 1980s, have given us information about health outcomes in Europe. I wanted to say that this is not a new idea. This is in 1886. This is a treatise by a doctor, a French surgeon, who was curious about differences in maternal deaths across Europe, and so he went and interviewed and visited different hospitals to see what might explain differences in maternal outcomes. So why are European comparisons useful, interesting? One, benchmarking. It's very useful. You can compare performance on key indicators across countries. And then you can use the differences that you see to reflect on care and the possible improvements. And I'm going to give a couple of examples looking at evidence-based interventions, breastfeeding, and cesarean section. European comparisons can also be interesting in European context because it makes it possible to corroborate or validate models that for universal effects, things that you expect to be true everywhere. If you can show that they're true in a lot of different contexts, it adds strength to your conclusions. I'm not going to discuss that, but that's also another very useful way of using the differences that we have in Europe. I'm going to use data from two different projects. One is the Perinatal project, which is a project that aims to monitor perinatal health in the European Union based on routinely collected health indicators. So this is information that comes from routine health statistics. And the scope of the project is maternal, fetal, infant health associated with pregnancy, delivery, and the postpartum period. And we have, in this report, produced two reports. The last one was on data in 2010, and we're hoping to come up with a new report soon. And this project has a website. And the other is a project called Effective Perinatal Care in Europe. This was a European-funded research project that brought together cohorts of very constituted cohorts of very preterm babies in 19 regions in 11 EU member states with a team of multidisciplinary team, people from obstetrics, pediatrics, epidemiology, and I'll talk a little bit more about that. And this cohort that we constituted, sorry, I don't have the data up on there, but the babies were born in 2011, 2012. We have funding and another research project to follow them up at 5 years of age. They're now, 2017, they're 5. So before I talk about some of the useful parts of comparisons, I'd like to give a few examples to show how careful one needs to be, because although it's interesting to compare across countries, we really need to make sure that we are comparing like with like, and comparisons are only informative if you really know that what you're comparing can be compared. I'm going to give a couple of examples of things that are difficult to compare. And it's important to have this in mind. There's so much data around, and the tendency is to want to rank countries one with respect to the other, and if you're doing it on the wrong data, you can get the wrong messages. I'm going to start with maternal mortality, which is not necessarily the focus of the group here, but obviously maternal deaths are very important, have an impact on the life of the child and the family. It's an important indicator for measuring quality of care. In a lot of audits, up to half of maternal deaths can be associated with substandard care. But the measurement of maternal deaths is very poor if you do not take special care to make sure that you are finding all of the deaths, mainly because a lot of deaths occur in the ICU, and the certifier may not know the woman was pregnant. It may not be the issue it may just not get onto the death certificate. And many countries have confidential inquiries or reinforced ascertainment, and they have been able to show that you can have between 20% and 90% of under ascertainment of maternal deaths. So when you look at maternal mortality rates, usually maternal mortality is presented as a ratio to live births. So you have maternal deaths as a ratio of 100,000 live births. And this is data from 2004. And when you look at the data, which are published, all of this, you will see a gradient that goes from 2 in Greece to 10 in the Czech Republic, and in France we have 7. So you can say, wow, there are 3 times higher rates of maternal deaths in some countries. But what I want to point out here is all the countries that have a little star are countries that have not done the work of doing reinforced ascertainment, have not done the work of doing confidential inquiries. And what you will notice about the stars is all the countries with the lowest rates are the countries where that sort of work has not been done. So personally, this data for me is meaningless, because you don't know. We cannot say that Greece has the lowest maternal mortality rate in Europe. It's not useful for us. This is some data from the Perinatal project from 2004, and similar questions arise when we compare stillbirth rates and neonatal mortality rates across European countries. Let me explain this graph. So, I'm sorry for people in the back. So, this is the stillbirth rate And it's divided up into the part of the rate that is due to deaths from babies born at 22, 23 weeks. This is babies born at 24, 27 weeks, and this is over 28 weeks. And what I would like to illustrate here is that the proportion of stillbirths that are due to these very tiny babies is very different across the countries. It is in 2004. It still is perhaps a little bit less today because I think assertion has gotten slightly better. And not only that, these deaths and births contribute to a large proportion of the overall rate. So based on this research that we did, the recommendation that we have in Europeristat is only when we do comparisons, to use the data for 28 weeks and over. You'll see that there's still a gradient. There are still differences, but you have to look at those differences intelligently and be able to extract from the rates that you're looking at those cases that are most likely to do with ascertainment. And I just one of the reasons I wanted to show the 2004 data is at that period in Sweden, for example, stillbirths were not registered below 28 weeks of gestation. So if you were just comparing national rates, Sweden would look like it had a very, very low rate. But if you weren't able to divide it up by subgroups of gestational age, you wouldn't know that's only because the lower gestational age stillbirths were not being registered. This is no longer the case in Sweden. And stillbirths are now registered starting at 22 weeks. This is neonatal mortality rate, and the same facts apply, even though we might think that infant live births might be better recorded than stillbirths. But we see in particular that 22, 23 week group has a very different contribution to neonatal mortality rates across Europe. And we know that these very peri-viable births that are live-born, that show some signs of life, in some contexts they're registered as stillbirths, in some contexts they're registered as live births, and in some contexts they may not be registered at all. So these are very useful, important indicators, but we need to be able to present them in a way so that they are capturing real differences and not these artifactual differences that can really change your impression of what the actual rate is. We've also just recently been doing some work on terminations of pregnancy and impact on stillbirth rates. This was something we were not even really aware of when we started the project, but in some countries, late terminations of pregnancies occur and can be quite a large proportion of stillbirth rates. And that's also important to know because a spontaneous stillbirth may not have the same causes, not the same etiology as a situation where you have a pregnancy termination for congenital anomaly and the terminations are just done later than they are in many of the other countries where terminations are done before 22 weeks to avoid having terminations in the viable period. I also wanted to present you some research that we've recently done on the APGAR score because this is something that is used a lot. We know it's used for the assessment of newborns. There's a set of components that everybody follows, rules that everybody follows. And it's used as a triage mechanism. But APGAR has been associated in many population studies with outcome, and both short-term and long-term outcome. And it's also available in many routine data sources. So it's an appealing potential indicator of morbidity. And in Europeristat, we actually do collect information on APGAR. So we decided to look at it, and here's information on APGAR less than 7. This is what we in our Europeristat report present. It's a low APGAR, and it varies in Europe from about 0.5% up to 2.4%. And what we actually did is we looked at the entire distribution, and we found very large differences in the way that APGAR seems to be assigned. And this was particularly clear when we looked at the way that a score of APGAR 10 is given. And it can go anywhere from 15%, 10-15% to almost 90% of babies that have an APGAR 10. Now, when we originally started showing these data, people were saying, yes, but people do, what they do with the well babies is just, that's convention, but this the under 7 is much more standardized. It's just the other part of the Apgar distribution that may not be. And actually, when we looked at correlations, we found that those countries that tend to give high number of 10s as a proportion of 9-10 also are more likely to give higher scores at the bottom of the distribution. So the whole distribution is affected by cultural perceptions of what Apgar means, how we give Apgar. And so here's an example from 3 countries just to give this is Norway, this is Scotland, this is France. Obviously, differences this big don't mean anything, but I think it's interesting to think about because Apgar is in all of our studies. We present it, it's considered a variable that is somewhat standardized. So it's not surprising that this isn't a correlation just of neonatal mortality and Apgar. It's not surprising that on the country level, you don't see a correlation because this is between low Apgar and neonatal mortality. Because very probably the way that each country, there's a lot of error around the way countries are assigning Apgar, and those differences make a different associations. However, we did find, just in defense of the Apgar score, that there was a correlation on a country level between changes in Apgar over time and changes in the neonatal mortality rate. So in those countries where Apgar increased increased or stayed the same, it actually did increase in some countries between 2010 and 2004, experienced a lower decrease in their neonatal mortality rate. And where Apgar decreased, the decrease in the neonatal mortality rate was higher. So trends over time may be meaningful. So maybe as a population indicator for looking at trends, it might be useful, but as a population indicator for comparing across countries, if you went back to this and tried to rank countries and say, well, Finland is doing really badly because it has 2.1% of its babies have an Apgar under 7, that is not a meaningful indicator. So after spending all this time making you feel like you don't want to compare anything across countries, I would like to now talk about why it's important to do this. I just think it's important to do this with your eyes wide open and thinking about what these indicators mean and how they could be measured differently. Because if you don't do it well, then people don't take any of the data seriously. Whereas I think it's important to do this. So one of the reasons that comparing international comparisons are interesting is it does not want to come. I have a little red circle that's supposed to show up, but all I wanted to say is this is data from our report in 2000. It came out in 2013, and France, as you'll see, is at the very bottom. And this is powerful for getting policy attention to some of our issues, is by saying, look, why are we at the bottom? Countries, people don't like that. It's a very powerful message. There's a certain national pride. You don't want to be at the bottom. It gives an idea of where you could or should be. So this got a lot of press in France. We also had a similar situation when we started the EuroPeristat project in the Netherlands, because the Netherlands did not do very well. Our very first reports were in 2000. Netherlands has always, through the 1980s, 1990s, was always one of the best performing health systems as far as maternal and child outcomes went. And they all of a sudden were at the bottom of the list. And this caused a lot of issues and just, I don't know, my little red circle, it did work for the Netherlands, okay. Just to show that here we compared fetal deaths between 2004 and 2010, and actually it's one of the countries that showed the most change. So starting with all of the attention throughout the 2000s, there were perinatal audits, there were a lot of work to try and figure out why the Netherlands had not done very well. And it's possible that this contributed really to getting the fetal mortality still birth rate down. So now I'm going to present a couple of examples from our a peace study on comparisons that we have done in care. So as I said earlier, this is a study that involves 19 regions and 11 EU countries. We put into place a population-based prospective cohort with follow-up 2 years. So data was from medical charts, and we also did a parental questionnaire at 2 years. And we also surveyed the hospitals and the neonatal units where the babies were cared for to look at their characteristics and their use of interventions. So a lot of the project is based on trying to improve the use or understand the use of evidence-based care for very preterm infants. And we know that implementation of evidence-based guidelines can be a cost-effective approach to improving quality of care. And there have been many studies that have shown that quality initiatives in the neonatal intensive care unit do actually improve outcomes. But one thing we know is that showing that something is effective is no guarantee that people will start to use that intervention. There are a lot of obstacles to using effective interventions, personal beliefs, the clinical setting, organizational factors, cultural factors, personal factors. And as we have seen today, yesterday, and I'm sure you'll continue to see, the evidence is often not that clear. So it's hard, and it changes. So there are a lot of obstacles in making sure that evidence, scientific knowledge is really translated into care. And so that was the objective of the PEACE project. And I'm going to present some research from one of our papers where we wanted to look at the use of evidence-based policy practices and see how that affected outcomes. So this is a paper that has been published, and we selected 4 interventions for the study. We used something called an all or none approach, which measures the use of, when you select a limited number of interventions that you feel are going to be related to your outcome, which for us was mortality or morbidity. They have to be well accepted interventions, and a sort of small number. And the idea is to see whether each patient got all of the interventions, not just each intervention separately, but whether the whole suite of interventions that you think are evidence-based were provided. Now, actually selecting the interventions was a lot more difficult than we maybe had anticipated, but so we picked 4 items that the group felt there was enough evidence to feel confident about expecting everybody to be doing them. One of them, obviously, delivery in maternity units with appropriate on-site neonatal care. Now, because we were doing it in Europe, we actually defined this both with respect to size, and also this is linked to the way that the level 3s and the level 2Bs were associated in each country. Basically what we did, we took the lowest common denominator as well, because our idea was we wanted every region to agree that this would be, that when it was not evidence-based, it was really not evidence-based. We didn't want to have an argument around that. Then use of antenatal steroids between 24 and 31 weeks, so under 24 we didn't include that in prevention of hypothermia, which we did as a temperature above or equal to 36. And then for surfactant use, there was obviously a big change in practices. So we just used infants surfactant within 2 hours of delivery or early CPAP, and only for infants less than 28 weeks. So in our cohort study, we had 10,000 total births, and 7,900 of them were live. And for this study, we used all infants without severe congenital anomalies admitted to neonatal care, which was 7,500 babies. So when we look at the receipt of the 4 evidence-based interventions, what we can see is overall most of the babies received each individual intervention. But when you look at all the interventions together, we found that over 40% of the babies were not benefiting from these 4 very basic interventions. And when we looked at the impact on mortality and morbidity, these babies receiving evidence-based care or not receiving evidence-based care, remember this is the whole suite of the 4 interventions. When not receiving care was associated with higher in-hospital mortality, severe morbidity among survivors to discharge, and mortality or morbidity. And once in adjusted models, it came out to be about 26 percent reduction in mortality if a baby had received these 4 different interventions. And we did a lot of propensity score modeling, and if you're interested, you read about it in our paper. So we can look across the regions that participate in our project, and indeed there were differences in the proportion of babies in each of these regions. That this is the percent of the babies not receiving all evidence-based practices by region. And one could rank them or whatever, but I think what's more interesting is to go and look at which ones of the interventions were, how each region performed with respect to the different types of intervention, and to note that some regions manage to do some things very well and have, for example, very few out of level 3 deliveries. Some regions also had, their issue was more around the antenatal steroids. This is true in France, for example. There's a big issue about antenatal steroids, especially at 24, 25 weeks, and this paper has contributed to a discussion. In some countries, there were a lot of really cold babies being admitted to neonatal care. And in others, it seems like our respiratory outcome surfactant was more of the issue. So what's more interesting when you do a study like this and then compare across regions is not to actually rank the regions, but to look at the fact that in each region there can be some dimensions on which one does really well and other dimensions in which one may be failing or doing less well. And for example, I point out the Swedish data where there was actually quite a bit of hypothermia, and this inspired, this is the Swedish region that participating in a piece is the region of Stockholm, and so this started a whole debate discussion on hypothermia and several papers that have been done on hypothermia by our Swedish team. So I'm going to just show you a couple more slides to illustrate the diversity that one can have for the care of this very preterm population. I chose the question of breastfeeding. We just had a paper accepted by the Swedish midwife who works with our team in Stockholm, so I thought I should showcase some of her work, which is going to be coming out in Maternal and Child Nutrition. And what we see in our European study is a very wide variation in the proportion of the very preterm babies that are breastfed at discharge home from the neonatal unit. Now, we all know that breast milk is associated with a variety of better health and potentially developmental outcomes. And a lot of the research has shown that we know it's difficult for mothers to breastfeed their baby in the neonatal intensive care unit. And there have been a lot of studies that show that unit policies can actually have an impact. Obviously, cultural factors are important too. So, but neonatal unit factors can have an impact. So this shows that any breast milk feeding at discharge can vary from about 30% to almost 80%. So a doubling of the babies that are going home on breast milk. Now, when you look at the situation a little bit closer, that's one level of variability, but we can find other levels of variability because when in some countries those babies are going home and they're exclusively breastfed, in others they're both breast milk and formula. And for example, our Italian regions, high rates of breastfeeding, and this is also true, this is Hesse in Germany, high rates of breast milk at discharge, but when you break it down, much lower rates of exclusive breastfeeding. And your ranking of your countries is very different if you are ranking on exclusive breast milk. I'm going to skip this and just come here. And your ranking is also different if you ask a question about whether the baby is actually feeding from the breast when they go home. And there are many, this is the percent of babies receiving any breast milk who are actually feeding from the breast when they go back home. So there are a lot of regions, and this is the Italian regions, and we have some of German and even Netherlands where the mothers are going home. It says they're breastfeeding at discharge, but the process of actually ensuring that breast milk is being given from the breast is not yet happening. So within the variability that we see in overall breastfeeding rates, we also see a variability in the way that breastfeeding is being implemented. I don't know if you can implement breastfeeding, but in terms of mixed and inclusive, and in terms of letting women, discharging pregnant women before the baby is feeding from the breast. And then I couldn't, this is not a paper that we've done yet, but it's something that's always quite striking when you compare across regions and raises questions. I just thought I would talk about, just show a couple of graphs from our study on mode of delivery for very preterm infants. This is the cesarean section rates for singleton live births less than 32 weeks that are in a vertex position. And again, this reminds us that care practices are quite different in Europe, and that you have regions where cesarean sections for these babies are low, 40%, 45%, and other regions, and in some where more and more, pretty much almost all babies who are preterm are being born by cesarean section, more in Italy and in Germany. Now, one of the difficulties of looking at overall cesarean section rates is that we know that some babies are born by cesarean because they are indicated deliveries, fetal growth restriction, so there's no choice of mode of delivery. So if you just look at spontaneous onset, the differences, the contrasts are even greater, and there are some countries where if you have a preterm baby, the spontaneous onset, the chance that that baby will be born in a vertex position, chance that that baby will be born by cesarean section is very low, whereas other regions where the probability that baby will be born by cesarean section is very high. And this is an area where we don't have great evidence about what should be done. I mean, the observationals, there have not been randomized trials are difficult. I think the one randomized trial that was tried had to be stopped, did not recruit enough patients. And then this is breech. But even within the breech area, there's a lot of differences. There's some countries where if you're a breech, very preterm baby, you are born by cesarean section. And then there are other regions, this is UK, France, Netherlands, where if you're a breech, very preterm baby, you may be a vaginal delivery. So very large differences, and the ranking again of countries is different. So Stockholm, our Stockholm region, for example, almost all of the breech, very preterm babies were born by cesarean, but if we compare Stockholm with spontaneous onset, still pretty high. But all I want to say is in Sweden, there's a very low cesarean section rate at term, but it doesn't translate. Sweden is more among the countries with high cesarean section rate for the very preterm. So I just want to say, just let you know about a new project that's beginning. It's called the RECAP project. And the idea is to create a platform of the very preterm cohorts that have been created in Europe, including the PEACE project that I just showed you some data from. These are child very preterm cohorts that have been done in lots of different countries. And then there are also adult cohorts, which means that the preterm babies are older now. And this project also involves the participation of the Nordic registers. So the idea is to put together a platform of data to inform people about the data that exist, and then to encourage people to use these data for postdocs, for doctoral students, and have it be as open as possible to researchers and investigators so that we can make use of these data. So I just wanted, this is my last slide. Instead of doing a lengthy discussion, I wanted to just go from, just tell you for me what international comparisons are best for. One, I think it's to let us know that better is possible. Looking around you, you can see, and better is possible along a lot of different dimensions. There's not just one good person and one bad person, but we can do better by looking at our neighbors and seeing what they're doing well. That can be inspiring. Second, when you look at the data from other countries and how they are doing things, I think it inspires you to think in a slightly different way. And the contrasts are greater when you look across countries. So it really, thinking out of the box, doing something in a different way is often where you go when you start comparing across countries. And then I think seeking win-win solutions. So the idea is not, oh, this model works really well, let's all become like the Swedes, or let's all become like the French. But the idea is to try and use this diversity to understand what works, and to try and integrate the components, the successful components in different systems and of care to improve outcomes and to improve care. Thank you.